Okay, once again, a very good morning, good afternoon, and good evening to those that have joined us for this session on the call to action for child survival in fragile and humanitarian settings. My name is James McEwen Patterson. I work for UNICEF HQ. I'm the Senior Advisor for Health and Emergencies, and I'm very happy to be joined by a colleague from UNICEF, Ralph Moreno Garcia, who is a health specialist on our team and is looking forward to sharing some very careful data analysis about the importance of this topic. We all share a passion for child survival, advancing the SDGs to making sure that we can fulfill the rights of all children to survive. We want to bring particular attention to the share of that burden of mortality that lies in fragile and humanitarian settings, and of course the challenges that all of us face to try and respond in those settings. I think many of the other sessions in this conference have tried to touch on specific approaches to doing so. The format will just be a single presentation delivered by Ralph, and then we can open up for some questions or clarifications, and I think even more importantly, your ideas and suggestions about how we can do better in responding for the needs of children in fragile and humanitarian settings. Before I begin, I want to maybe just double check that indeed I'm audible and that the French interpretation is working okay for those that want to use it. Anybody wants to give a thumbs up or indication that that's working, that would be great.
Yes, the French audio is working.
Wonderful. Okay. So with no further ado, I will invite Ralph to start his presentation. If anyone has really pressing questions, I would encourage you to note those down in the chat. We'll be monitoring that together to make sure that we don't leave any important thoughts or questions unanswered. And then at the end of the presentation, we'll open up for your thoughts and discussion. Thank you.
Thanks, James, for the introduction. And before I start, I want to check that you can hear me well and you can see my screen.
Yes,
Perfect. Thank you very much. So as James mentioned, my name is Ralph Moreno. I'm a health specialist in the Health in Emergencies and Humanitarian Settings Unit in Health in UNICEF headquarters. And today I'm going to give you a presentation on the health situation of children living in humanitarian and fragile settings, a call to action. So I'm going to walk you through the structure of the presentation. We have a background, the objectives, the methodology, the results, which are based on selected SDG indicators, and the conclusions. I will start with a brief background. I'm sure that you are aware of all these challenges, but I would like to mention them once more. We have different bottlenecks and issues when working in a fragile or humanitarian setting. One of the most important ones possibly is the socioeconomic and political instability that in turn lead to disruption of different essential services, right? We have wash services that are not working well. We have malnutrition, and importantly, we have disruption of health services. We also have populations on the move, internally displaced people, but also refugees. We have limited governance. And also one of the important factors is violence, conflict, and issues regarding accessibility and provision of key services to vulnerable populations. We also have destruction or damaged infrastructure, and we have important data gaps that limit our capacity to tailor our programming to local needs. In this slide, I'm showing you the overall classification that exists in terms of humanitarian and FCV settings. There are several of those. For this presentation, I'm going to focus on the first two ones, the one by OCHA, which describes countries that are facing a humanitarian situation, and those countries have a humanitarian response plan, and the classification from the World Bank in terms of fragile, conflict, and violence countries. To your right, you can see a map where we have identified countries that are either humanitarian and or FCV for 2023. There are some countries that are included in both lists, but sometimes you find some of those countries either in the humanitarian or on the FCV. For that reason, we have analyzed countries, both that have been included in the humanitarian and or in the FCV. This is a slide to give you a sense of the magnitude of the crisis in countries classified as humanitarian per OCHA's Humanitarian Response Plan. And we can see, for example, that in places like Pakistan, Afghanistan, and Ethiopia, more than 20 million people are in need of all sorts of services because of the crisis taking place there. What is the objective of this presentation? So we want to describe the health situation of children and their families in humanitarian and fragile settings, highlighting the inequities. The methodology we use was analyze publicly available data sets from different sources, WHO, UNICEF, and World Bank, understanding that there is harmonization between those data sources, but also others that also may be available. Most of the presentation uses descriptive analytics and some inferential components. And we are describing absolute numbers, rates, arithmetic averages, and also we did some time trend analysis. For the time trend, again, we had a humanitarian cohort and a fragile cohort of countries. And what we decided to do is include in the humanitarian cohort those that have been in the OCHA's list for more than 7 years during the last decade. Something similar we did for the FCV. Those countries mentioned in the FCV list from the World Bank for more than 7 years during the last decade. And the indicators we analyzed were those SDGs closely related to child health or those for which UNICEF is the guardian. And we have divided them into epidemiological indicators, for the most part mortality, and also in terms of service provision indicators. Results. So this is the first slide that I would like to show you, and there are a couple of takeaways here. When analyzing the three main mortality indicators, that is maternal mortality ratio, newborn mortality rates, and under 5 mortality rates, we see a pattern of decreasing mortality during the last 20 years. However, there are a couple of things that happen here. The first one is that the reduction in mortality is different according to the specific indicator we're looking at. The more modest is the one on maternity mortality ratios, where there has been a decrease of 34%, higher for newborn mortality rate 42%, and the highest gain has taken place around on the 5 mortality rate. Having said that, it's clear, as you can see in the blue or the orange lines, that a decrease in mortality is not as much as we would expect in FCV and humanitarian when compared to the world averages, right? If you look at the maternal mortality ratio, the humanitarian cohort has probably twice as much mortality as the world average. If you look at the newborn mortality rate, the difference is of around 39%, and on the 5 mortality rates is of 68%. This is to say that although we have had enormous gains in terms of mortality, those gains are not homogeneous across areas or different cohort of countries, and in FCV and humanitarian settings, it's not as much as for the world average. In this slide, I'm showing you the absolute numbers in terms of under 5 mortality for the last available data point we have, which is 2021. That year, there were around 5 million under 5 deaths. And of those 5 million, more than 50% took place in humanitarian countries, and around 44% in FCV settings. Also, it's important to highlight that of the overall under 5 mortality, nearly half of them are newborn deaths. Following up on that last piece of information, if you take out all the global deaths for newborns, which in 2021 were 2.3, we saw that nearly half of them take place in humanitarian settings and more than a third in FCV settings. In this slide, we want to highlight 2 or 3 takeaways. The first one is the impact that crises have in child mortality, and we selected some examples of that impact. The first one is Niger. If you look at it, from 2000 to 2010, there was a decrease that was important in terms of under 5 mortality, but in in 2011, we have the acceleration and almost flattening of the curve. And that coincides with the crisis in the Sahel, which started in around 2011, where we have violence, conflict, displacement, and other factors are related to crisis. We also have the example of South Sudan, something similar, the acceleration, and around 2011, after the independence process that triggered additional conflict and issues in the country, we have a flattening of the reduction in mortality. In Haiti, we have a slightly different behavior where we have a peak in mortality in 2010 associated to the earthquake and the cholera cases there. In Yemen, also this acceleration. We have flattening around 2011 when the initial protest followed by the Arab Spring situation. And then in 2014, we have a reverse in health gains when the conflict exploded, let's say. And Syria, something similar. In general, low mortality rates. And then in 2011, we have an increase, a peak in mortality. A second point I would like to make here is that the increase in deaths could be direct or indirect. Direct because of the trauma, violence, and the outbreak that may have taken place during this crisis. But also there's an important component of indirect mortality when there is disruption of essential services. Clean water, malnutrition, and disruption of health services, as we saw during the COVID-19 pandemic. In this slide, I'm showing you the first of the service indicators, and we have selected DPT as one of the most important ones for different reasons. It's an excellent proxy for access to other vaccines and also other health services. We all know that DPT-1 is also the indicator that we use to assess zero-dose children and communities, which are those that haven't received any vaccine and possibly any other health services, right? So first, I would like you to focus on the figure on the left. If you see the behavior of vaccination during the last 20 years, we have an increased coverage, but in 2020 and 2021, there was an important drop, which coincides with the COVID-19 pandemic. And actually, the pandemic just put us in a situation in terms of coverage that we hadn't seen since 2008, right? Like we went back around 50 years in terms of coverage of vaccines, it's of vaccination. So it's a terrible situation. That decrease in coverage also is reflected or mirrored in fragile and humanitarian settings. That decrease in coverage has had a terrible effect. We have started to see reemergence of certain pathologies. Last year and this year, we're facing measles outbreak in different countries worldwide. Also, we started to see some polio cases in countries that never had or hadn't had polio in many years. In the right, it's sort of a zoom of this area where we saw a drop between 2014 and 18-19, which coincides with the upsurge of conflict and crisis in many of the countries that we have analyzed in this presentation. So we see a drop in DP3, for example, in Syria. Also, we see something similar for South Sudan or for Yemen. Myanmar has had a different behavior, and we saw a drop after 2020 and also in 2021, possibly related to COVID, but also on the local on the current situation in terms of the political instability and change of government. Another indicator is skilled birth attendance. 2 or 3 things I would like to highlight in this slide. The first one is that there is lack of information from many countries worldwide on this, and particularly in humanitarian and FCV settings. For example, when I was trying to analyze this particular indicator, I only found around 38, 39 countries that had more or less recent information. And by recent, I mean after 2015, that's almost 8 years ago, right? But only 39 countries combining FCV and humanitarian had information, right? So that's the first takeaway. The second, and there's no surprise here, The higher the income, the higher the access to SBA, right? So if you look at the averages for low income, lower middle income, and upper middle income, it increases as the income level also increases. In the right, a couple of things I would like to show you. The first one, that there is a strong association between access to skilled birth attendance and newborn mortality rate. There is a reverse correlation where the higher the skilled birth attendance, the lower the newborn mortality rate. You can see that there is a clear line showing this association, and when running a correlation coefficient, the number is around 0.7, which is very close to 1, showing us this strong correlation, right? But also, I want to show that that may not be the only factor behind this, right? We have additional variables to decrease related to maternal newborn mortality, such as access to water in healthcare facilities, quality of care, mother's nutrition, mother's education, etc., right? And income could be a proxy for those. And when running the correlation coefficient, we saw that it's a moderate to high correlation between these two variables, income and newborn mortality rate. The last insight from this slide are the countries around here, which don't really fall strictly into the direct correlation between skilled birth attendance and newborn mortality rate. For these countries, there could be additional variables explaining that high mortality rate in newborns and moderate access to skilled birth attendance, which are the ones I just mentioned, right? It could be a matter of nutrition of the mother, access to additional services such as WASH, for example, or the quality of service could also be one of the possible explanations for that finding. This slide shows us the density of healthcare staff in humanitarian fragile settings. Although UNICEF is not one of the guardians of this particular indicator, is nonetheless a very important one, since it's one of the main bottlenecks to provide healthcare services. So if you don't have healthcare workers, it's how are you going to provide healthcare services, right? And the difference is staggering when comparing the global averages to what's happening in humanitarian and FCV settings. I'm not showing here the correlation with, the difference with high income countries, because otherwise will be, I don't have a space to show it. So in terms of physicians, for example, there is a difference of 8 times between the world average and what's happening in humanitarian and FCV settings. And when it comes to nurses and midwives, the difference is also staggering, right? 6 times in humanitarian and 3 times in FCV settings. So this is a follow-up slide from the previous one, and it's about community healthcare workers, which is a priority for UNICEF and all of us working on the international health arena, since it's one of the mechanisms to address that lack of healthcare workers in fragile and humanitarian settings. In this slide, we did an analysis of the average reduction of under 5 mortality during the last decade. So the average reduction of FCV countries in terms of under 5 mortality was of 17 points. However, when you do a sub-analysis separating countries that have a community healthcare system in place from those which don't, we saw a very interesting finding, and is those having a community healthcare system in place have a reduction of 21 points, and the ones which not have, the reduction is of 13 points, and the difference is significant. Although this is still ongoing analysis, the results points towards a strong correlation between having a community healthcare system in place and an important reduction of under 5 mortality. The key messages from the presentation, we'll know that there have been important global health gains in terms of mortality and access to health services during the last 20 years. However, those gains are not homogeneous across geographic regions or specific cohort of countries. In this case, the humanitarian settings and fragile settings are far from world averages. That means that if we don't invest and put an important focus on the health and the overall social environment in humanitarian and fragile settings, we will not be able to achieve the SDGs. We also know that crises have a vast impact on populations' health status and the provision of services. And usually that impact takes time to recover from. Additional insights from this analysis is that there are multiple variables outside health. From our side, we work on health. However, the social determinants of health are very important in health outcomes. And according to some literature, for example, up to 50% of the burden in health could be explained by other factors outside health. So it's also very important to work with other sectors. The quality of services is also key. So we should strive for increasing the services to populations, but as we do so, we also have to work on the quality. We should continue maintaining and expanding all services for mothers, newborns, and children. However, as we saw, the gains in maternal and newborn health have been more modest. So we should continue striving to increase these services and improve them in terms of quality. This is no surprise, lack of data in humanitarian settings, but if we don't know what's happening, it's difficult to tailor programs and better respond to the needs of local communities. And there are multiple bottlenecks in terms of the provision of services, but one of the key ones is healthcare staff. What actions we recommend, and that's something that all of us have been trying to do during the last decades. Sorry. First, advocate for universal healthcare with a focus on primary healthcare interventions, trying to provide a full package of services that are adapted to the local situation of humanitarian FCV settings. As I just mentioned, multi-sectoral collaboration is key. If you don't address nutrition, wash, and other components, the health gains are going to be more modest. It's also very important to work on strengthening HMIA systems, either via the HS2, civil registration, or whatever system exists in the country, so that we have a better understanding of what's happening and we can better tailor our policies. Bridge the humanitarian development gap is a key outcome that we want to achieve. When you work in the humanitarian space, it is of the utmost importance to provide access to key services that population lack, but also we should work all together into creating capacity at a local level, working on localization and coordinating with partners so that those communities are better prepared to face the next crisis that is going to take place, and ideally to prevent it as much as possible, right? So emergency preparedness and response is key for that. In this case, adapted to the health response, right? We should continue working on high impact interventions for maternal, newborn, and child health, and we are aware of those. Skilled attendance is one of the most important, but also antenatal care, access to oral rehydration salts, zinc, antibiotics, mosquito nets, and prevention and treatment of malaria in general, and immunization. Those are key interventions, along with the overall efforts to improve primary healthcare and expand it that we should continue supporting. Community healthcare workers, as I just mentioned, is one of the key interventions for addressing the lack of healthcare workers in these fragile settings. And we should strive to continue expanding and improving the services delivered to populations that are out of reach or that are in remote areas or who are migrants, displaced, and in general vulnerable. That's at the end of my presentation. Thanks for your attention, and I will give the floor to James for some closing remarks, and then we can take some questions you may have.
Thanks, Ralph. Really a fantastic presentation. I think you really set the stage very nicely. Starting first, really appreciating the good news, the optimism that despite emergencies, despite crises, there is progress in child survival across the world, including in fragile and humanitarian settings. But we see that many of those countries are stuck in that situation for a long time and are not advancing as quickly, so are less likely to celebrate and have the joy that I think each of us have in various countries when we're part of an effort to meet the MDGs or to meet the SDGs. It is always so exciting, and we really want to see that happen for all countries, for all children. It wasn't, of course, the focus of this presentation, but I think we only have to open the newspaper to realize that crises seems to be multiplying. I know for UNICEF and perhaps for your organizations as well, the number of crises, big and small, seems to increase every year. Both man-made conflict and armed conflict forcing population displacements, as well as natural disasters, most exemplified, in my opinion, by the flooding that was experienced in Pakistan last year, which was on a scale that I don't think we've seen ever or in a very, very long time, and something that I think we all fear we're going to see more and more. So the importance of strong, resilient health systems for countries that maybe today are not classified as humanitarian settings or fragile may, sadly, in the near future, have some very, very difficult challenges, and hopefully there's some resilience. I also really appreciate, Ralph, how you zeroed in on some of the interventions that have continued and also have struggled, as well as the systemic challenges such as HR that need to be overcome. I've been excited to see across this virtual workshop a number of presentations that have tried to look at interventions to respond to fragile and humanitarian settings. Community health workers, as Ralph highlights, is one that many of us are pursuing as a way to not overcome, but certainly to mitigate some of the human resource challenges faced in areas of fragile areas and humanitarian settings. I was excited to see some very important quality improvement programming that was being done in Mali, for example, to really ensure that facility-based care is also keeping up to the best possible standard it can, even in the most remote and challenging locations. So thanks, Ralph, for that great presentation. And just checking now on some of the comments. I don't see any hands up, but please, colleagues, if anybody would like to complement with their own ideas or experiences or ask a question, please don't hesitate to do so. The floor is open. See one question. Ralph, on the localization of humanitarian emergencies, could you expand on what UNICEF may be doing in these regards?
Sure. So we are working on so many different things, right? But in terms of localization, we work on training of different populations, let's say. We work with governments to increase the capacity for example, emergency preparedness and response, and better understanding what are the local risks to better address those risks in the future. We also work on training of healthcare staff who are working in these settings, right? And we have worked on different things such as HIMCI. We're working on use of PPE. We're working on better use and analysis of data. We also have worked on training of community healthcare workers to improve the quality of the service they provide through digital means and other mechanisms. And we also work with the communities. In the community, you provide education, OSBC services to improve behaviors such as hand washing, for example, right? That has an implication in many other many infectious diseases. That's one of the mechanisms we have used for improving localization, the training of different target populations where we are operating.
Thanks, Ralph. Yvette has a question about sustainability in terms of HIP. I'm going to guess that's high impact practices. Thanks.
It's humanitarian implementation plans. Could you
please?
No,
it's high impact practices. So sustainability of high impact practices and interventions in humanitarian settings. So the core of the question is, could you comment a little bit about sustainability, Ralph?
So high impact practices and sustainability. High impact practices Well, there are things that have been identified across literature and what we know that have an important impact in the decrease of mortality of children. For example, prevention and treatment of malaria, mosquito nets, and artemisinin, for example. We can work also on the community management of malnutrition. We could work also on the provision of oral rehydration salts, zinc, and other interventions. So as I would like to mention my previous answer, right? When you train local communities, you have the ability to sustain that response across time. If you do it with community healthcare workers, for example, they're in a better position to provide treatments and diagnostics for one of the key killers of children, that is pneumonia and diarrhea, for example, and also management of malaria. I always refer to those three because are one of the big ones for under 5 mortality, right? Training, it's key and essential. There are additional aspects of sustainability and impact that sometimes are more elusive depending on the political and financial scope that we are at, and also the donors, right? For those, the sustainability across time may be more challenging, and that's the reason why we should continue doing these kind of practices, working on advocacy, making everybody aware that humanitarian and fragile settings are in a dire situation, and if we don't continue working with them, both in a technical capacity, but also with financial support, it's going to be difficult to sustain gains or to reverse some of the losses that we have had, precisely because there is not constant donor support across time, for example. And I'm talking about the most fragile settings, right? That question also touches one of the key issues in development, not only for health, but overall, and is how to sustain that across time. And again, the best answer that I could think of right now is working on advocacy, working there and showing that these interventions work, so that everybody in the international arena continues the support in one way or the other, technical or financial.
Thanks, Ralph. I might come back a little bit to comment on that, but I see Full Maureen has her hand up. Would you mind to come in?
Thank you, James. Thank you, Ralph, for the wonderful presentation. My hand was up just to share our experience, especially with the use of community health workers in the fragile setting in Cameroon. I work with the Cameroon Baptist Convention Health Services. We are health providing organization, but when we were faced with the crisis, it became difficult even for the big hospitals we have to be able to meet the needs of the people, because there were a lot of internally displaced people, and many people didn't move to the urban areas. They moved into more hard to reach areas. So it became very difficult because you could not move the hospitals, you could not move the health centers, and we had to resort to using community health workers. And the results were tremendous. And talking about them in the place of sustainability, even when the funding kind of ended, we still have the community health workers offering services because they are part of the community. They live with the people, they see the needs. And it's common for me to wake up in the morning and the CAW calls you, or I've screened about 5 children that I saw with some signs of malnutrition, and 2 are Sam, what do I do? And then we work together. The children are still supported, even though there is no funding. Just to say that in the fragile settings, the community health workers are really a strong force to reckon with, and where you cannot go, they easily go, because one of the challenges too we had in our context was that access was really difficult. So it was easy to use community health workers for you to move from a hospital to a community where you're not known, because you could easily be mistaken for something else or for somebody else, and you might not even come back to tell the story. Thank you.
Thank you, Fulmarine. I hope I say your name correctly, and maybe just a shout out.
Yes.
Fulmarine and colleagues have done a poster presentation on the experiences in Cameroon, really emphasizing what can indeed be accomplished. So if you get a few minutes, good to go and have a look at some of those examples about how we can respond with action in humanitarian settings. There was a comment from I'm not sure I know what the name is, fragile settings has a risk putting in place interventions to reach all children, but no special interventions for children in most fragile settings with the risk of aggravating inequities for the most vulnerable children. Ralph, do you want to comment on that? Are inequities growing?
I guess is Gobonsima the one who made that comment, right? And
yes.
the risk, yeah. So yeah, that's a difficult situation to address, but we in UNICEF have tried to overcome that through different mechanisms. One of those, there are two mechanisms actually. The first one is the nutrition and health and mobile teams to reach out these populations who are usually vulnerable, remote, that are part of crisis settings, populations that are usually migratory, could be IDPs or refugees. And this is something that we in UNICEF do extensively, especially in the most vulnerable settings in humanitarian situations. That's something that we have developed, trying to reach out to those who may be left out from the main healthcare systems and social systems, right? And the second one, which was part of my presentation, is providing services through community healthcare workers. They're part of the community, and even if it's a remote area, these community healthcare workers are already there. They know the needs, the cultural practices, and are a link between the mainstream, let's say, or facility-based healthcare system and those who are remote. We understand there are still gaps, but we all are trying to close those gaps through these and other interventions like task shifting, etc. Happy, I mean, let me know if you would like to add something to that, James, or if we would like to take another call, another question.
I'll come in a bit later. Elizabeth had asked a question about priority interventions for neonatal care at community level. Would you want to see a focus on this given the relative mortality in this age group?
Sure, there are a couple of things that we could do there. IMCI is one of the important ones because you have to teach community health workers and mothers signs, concern, and hazard signs in children, including neonates, right? Such as, for example, fever, hypothermia, neonates that don't eat. Those are signs that are showing you, well, we need healthcare, right? That's part of the interventions. Also, something that we could do is, although it's a long-term intervention, is education of women and mothers. When you have a more educated woman, they are aware of when to look for support and bring their kids to the medical doctor, or also just general practices that are going to be conducive to a higher survival of children and neonates, such as, for example, hand washing, exclusive breastfeeding, and others. That's something we could do at a community level. And of course, we have to strengthen all the additional referral system and the services provided at healthcare facility, which is, outside of the community question you asked, but it's also part of the overall network of services that we should be providing, linking community with facility-based services.
I see some others are chiming in as well, reminding about the importance of kangaroo mother care and postnatal visits that in many contexts community health workers can provide. Maybe if I can complement, I think for the last 20 plus years, I think as a group of public health professionals, practitioners, we are so fortunate to have this incredibly strong body of evidence about key interventions that we are trying to take to scale. I think what we've been learning steadily over time is the ability to task shift and see different health systems deliver those interventions. So I think for me, the loudest call to action is to accelerate that adaptation in fragile and humanitarian settings. The Child Health Task Force, as many of you will recall, was first set up to be the champion for ICCM, task shifting IMNCI into the community to bring treatment of malaria, diarrhea, and pneumonia into the community, and with incredible success. Back in 2020, not so long ago, there was a review of community health worker programs in emergencies that found, exactly as Ralph has described, an incredible resilience because community health workers are a part of their community. Not always, but almost certainly in community health workers, they are uniquely attached to their communities. There are many cases where nurses and midwives are also part of their communities and move with their communities, similarly for doctors, but sometimes they are imported from outside. So community health workers bring that resilience, and where we're able to task shift interventions with community health workers, we can do so much. But I would maintain that there is significant challenges for newborn care because we know that the evidence base really does center around a health facility. It centers around skilled birth attendants and has to date not been something that we can task shift in full. So we can certainly help create demand generation. We can encourage good antenatal practices. We can encourage care-seeking behavior. We can promote KMC, kangaroo mother care. We can do some postnatal checkups on the first day and 3 in the first 3 days in some countries with community health workers. But very often they will need to be referred to a health facility. That's for those of you that have followed the rapid scale up of sick newborn care units or neonatal intensive care units, called a variety of things. We have similarly seen it's a large task shifting for what was 15 years ago reserved for pediatricians and neonatologists. Increasingly, a physician or a nurse practitioner with a small team is actually doing remarkable services within a health facility with relatively modest equipment supply, with relatively modest drug supply. So I think we can continue to look again for that evidence of adaptation that we can bring into fragile and humanitarian settings, particularly some of the most challenging settings. That's what I think is a group of practitioners and researchers and advocates that we need to continue to look for that, so that the current inequity, which remains, let's just say, stubborn, right? These countries stay far behind, these contexts stay far behind, that we could start to see that narrow, that we could drive investment towards those areas for innovation to see that gap narrow. Sorry, that was a rather long intervention. Opening up the floor, and if any of the moderators, I think there was one question about whether community health workers are compensated. From Kriti, I think that was a question about Cameroon, if I'm not mistaken. Were your community health workers compensated?
Yes, James, when the funding was available, there was compensation for them. And at the very beginning, we made sure they were informed that funding was going to be for the time period, but we also encouraged them to make sure that what they learn, they should be able to keep it up, because it's going to help the communities. And at the level of our organization, we have a primary healthcare department that makes use of community health workers, but they are called motivated by the community, and our organization gives a kind of a top up. That one was still.
That's excellent.
But in the fragile setting, we had people who were available in the area.
Excellent. And I think we saw recently in the World Health Assembly, we see Africa, CDC, and many other very high-level political actors really pushing for a scale-up of community health worker systems. And as that question described, and as that practice described, really encouraging that domestic budgets contribute to paying this incredibly resilient and capable workforce, recognizing the important work that they do. Can I ask our other moderators if I've missed any questions? Have we got them all? Or if anybody feels that their question has got overlooked, by all means, raise your hand or repeat it in the chat.
I guess we have
Just
covered most of the questions, right? Somebody else would like to share something else, or maybe just open up their mics and formulate a question. We are happy to continue the discussion.
Olu's question is on partnerships with other key stakeholders, examining how digital health can address these stubborn inequalities.
That's an excellent question. We have a couple of examples there, and digital health is one of the different work streams we want to continue advancing. So we have a couple of examples, like in Mozambique, for example, the Upscale project, where we want to provide training and also data collection via a digital platform and application that help us getting community healthcare workers trained and with knowledge on some conditions, facilitating the provision of services and also increasing the quality of services. And at the same time, as I just mentioned before, doing some data collection at a community level to have a better understanding of the local needs of communities.
Thanks, Ralph. I see we just have a few minutes left, but if we've exhausted all the questions, we can also just express our thanks for everyone's participation and great questions. Ralph, for the great presentation that you've delivered. Our moderators for making the technology work so beautifully. And thank you especially to our French interpreters to make sure that this was inclusive for more people.
And thanks to you, James, for the moderation, the support, and to all of you for joining us in this exciting discussion.
Thanks. Thank you, everybody. With no further ado, I'll say a final word of thanks and wish you all a great remainder of your day, or if it's
Thanks,
late
everyone.
for you, wish you a very good rest with your family and loved ones. Thank you.
Thank you, James. Thank you, Ralph. Thank you, everyone.